My presentation will not be too long. This is what was accepted for AUA in a podium session. These are the preliminary results of our HIVEC HR trial in high-risk non-muscle invasive bladder cancer, comparing chemohyperthermia with HIVEC with mitomycin C versus BCG. So we know that currently there is no alternative for BCG in high-risk non-muscle invasive bladder tumors apart from cystectomy in certain cases, and also that in the recent years there have been several BCG shortages which have made us look for an alternative for this population of high-risk non-muscle invasive bladder cancer. So our aim was to explore whether residual hyperthermic intravesical chemotherapy with mitomycin C is an alternative to BCG in high-risk non-muscle invasive bladder cancer patients. We designed a pilot trial to explore the effect of this medication in our center, prospective, randomized, and open label with 50 patients to include. As you can see on the right of the screen, we did the TURBT. The postoperative mitomycin instillation was optional. Most of our patients receive it, but sometimes if there's a contraindication, there's no instillation. And those patients which were at high risk, according to the EAU guidelines, with no CIS, were randomized to receive either BCG for 1 year with a SWOG schedule, or chemohyperthermia with HIVEC mitomycin 40 milligrams. We did a six weekly installations induction period, followed by a 6-monthly installations maintenance period. The main outcomes for this trial were to explore the 24 months recurrence-free survival, the progression rate, cancer-specific survival, the safety of this new alternative, and the quality of life of our patients. So as you can see on the left of the slide, all those patients operated in our center with non-muscle invasive high-risk bladder cancer, that is T1 or high grade or G3, all of those who accomplish all the following conditions, which are TA, G1, G2, who are multiple, more than 3 tumors, and recurrent and bigger than 3 centimeters. We excluded those patients with CIS, those patients, of course, with allergy or hypersensitivity to mitomycin C or adverse reactions to BCG, and those patients with a tumor, urothelial tumor outside the bladder, like upper urinary tract or prostatic urethra. Also, those patients with variant histologies were excluded from the trial, and those patients with urethral stenosis contraindicating the catheterization for the installations. On the blue table of the left of the screen, you can see the baseline results of our patients. Both groups are comparable. We see they're well balanced, but for one feature, which is the previous recurrence rate of some patients. Those highly recurrent patients with more than 1 recurrence per year were 16% in the BCG group. We had 4 of these patients in the BCG group, and there were none of these patients in the HIVEC group. That's the biggest difference between the baseline characteristics of both groups, and we'll talk on that later with more results we will present. Regarding the efficacy analysis, we see that in the intention to treat population, there were 6 recurrences in the BCG group and 3 recurrences in the HIVEC group. From these 6 recurrences, 5 of them were progressions to muscle invasive bladder cancer in the BCG group, and from these 3 recurrences in the HIVEC group, 2 of them were progressions to muscle invasive. It's important to say that 3 patients from the HIVEC group at the moment of the analysis of the data had a recurrence diagnosed with a cystoscopy, but had not yet undergone
presents our abstract that we presented at EAU this year virtually, and it's on intravesical chemohyperthermia using the combat system in patients with BCG unresponsive non-muscle invasive bladder cancer. And this represents a multi-center European registry from 15 different hospitals. So this is my conflict of interest slide. So the recommended treatment for BCG unresponsive non-muscle invasive bladder cancer represents radical cystectomy, although we are all aware that not everybody might be a candidate for radical cystectomy due to comorbidities or due to patient choice. And there is an increasing need for alternative treatment for this cohort of patients. And here we report oncological outcomes in patients with BCG unresponsive non-muscle invasive bladder cancer treated with adjuvant chemohyperthermia using the combat system. So there's several ways how hyperthermia works when delivered intravesically. It works by increasing the cytotoxic ability of chemotherapy, by increasing the permeability to deliver drug across to the cancer cells. It denatures proteins, it releases hit shock proteins, and works by activating T cells as well. And all these have been proven in preclinical models, and all these would lead to cell necrosis as well as cell apoptosis. So this represents a multi-center European retrospective cohort of patients from 15 institutions where they were treated between 2011 to 2019. Chemohyperthermia here was delivered using mitomycin at 43 degrees Celsius over an hour. And BCG unresponsive disease, this represents standardized definition used by the FDA, and that's what we adopted for patients in this group of patients. And the primary endpoint for this study was 24-month disease-free survival and progression-free survival. And for the patients with CIS disease, we also looked at 6 months complete response rate. So in terms of our patient cohort, we had 135 patients with the median age about 70 years. As expected, most patients were male patients and most patients had a smoking history. T1 disease accounted for 36% of the cohort, and CIS-only disease accounted for 25% of the cohort, with 12.6% of patients had concurrent CIS with papillary disease. Over about 60% of patients had grade 3 disease, and these patients had a median follow-up of about 14 months. So this represents the results. The table, the Kaplan-Meier curves on the left represents recurrence-free survival curves, and in terms of the right represents progression-free survival. If you look at 12 months follow-up, roughly depending on the type of disease, we stratified the disease here to papillary-only disease as well as CIS plus minus papillary disease. And as expected, if you've got only papillary disease, this group of patients would do better compared to CIS plus minus papillary disease. And the results here at 24 months follow-up suggest that with papillary disease, recurrence-free survival is about 62%, and this falls to 36% for patients with CIS plus minus papillary disease. In terms of progression-free survival with 24-month follow-up, not many patients actually progress to muscle-invasive disease, suggesting that this is a pretty reasonable treatment option. So how does conductive hyperthermia compare with other treatment modalities? A lot of you might be aware that recently the Keynote 057 study, where they looked at pembrolizumab single-arm study at 102 patients with BCG unresponsive CIS plus minus papillary disease. This has recently been FDA approved and presented at ASCO GU as well as the main ASCO, with a complete response rate at 6 months of about 75% and a disease-free survival rate of 53%. Historically, berubicin was approved in the past before, and this has not really been uptaken in most centers because of its pretty poor oncological outcomes. Also recently in 2020, this adenovirus recombinant vector, this represents intravesical treatment where they look at 103 BCG unresponsive CIS disease as well as some papillary disease with a 6-month complete response rate of between 53% to 73% and a 12-month disease-free survival of between 24 to 44%. And also on the far right, this represents, of course, the current study and previous studies that I published in terms of using hyperthermia treatment as well. So if you compare the combat treatment that we report today compared to the pembrolizumab data. It's actually pretty similar-ish results in terms of 6 months complete response rate as well as 12-month disease-free survival rate if you compare CIS plus minus papillary disease. So in conclusion, our data would suggest that in patients with BCG unresponsive non-muscle invasive bladder cancer treated with conductive hyperthermia, 24 months overall recurrence-free survival was about 54% with a progression-free survival of 92%. Chemohypothermia seems to be a valid treatment for this group of patients who are unsuitable and who are not keen for radical cystectomy. Of course, this represents retrospective data and prospective data as well as randomized studies will always be welcomed in terms of validating these results. So I also want to share with you some of the outcomes of recent and pending upcoming RCT outcomes using the COMBAT system. So this was presented by Felix Guerrero's group based in Spain. So they randomized 50 patients who had BCG naive high-grade disease, papillary-only disease to COMBAT as well as BCG. And what they showed was it was comparable oncological outcomes at 24 months. This was recently accepted at the AUA, and the full paper is currently being written up from what I've been told. This understandably represents a small cohort of patients, 50 patients, and might not be adequately powered to look at any difference in terms of the two different treatment modalities. And there are also two upcoming studies, HIVEC 1 and HIVEC 2. So these represent randomized studies with well-designed studies with power calculations, and they're looking at intermediate risk disease, and patients were either treated with cold room temperature mitomycin or 30 minutes of heated mitomycin or 60 minutes of heated mitomycin. And results of these studies should be coming out anytime soon now. I know for HIVEC 2, the 24-month follow-up data was up to January or so, and the data is being cleaned at the moment. So these results are eagerly awaited. So thank you very much for your patience and your time, and I appreciate that lots of you